Good afternoon, and I'd like to thank the organizers for inviting me to give this presentation on this fascinating disease. I just don't want to move. Okay. All right, so let's start with a case. And I want to keep this talk a bit general because I'm not sure that the audience is deeply steeped in this disease, and I want to make sure that patients understand the biology of this disease. So we have this is a typical patient, a 35-year-old male with fatigue, pallor, shortness of breath, is found to be anemic with an elevated MCV. His white cell count is at the lower limit of normal, platelets somewhat reduced, but he has a very high reticulocyte count, and morphologic evaluation of the blood shows macrocytosis and reticulocytosis. The bilirubin is elevated, most of it is indirect. This will be compatible with hemolysis. Other liver function tests are normal, but the LDH is very high. The antiglobulin test is negative, which will make an autoimmune hemolytic anemia unlikely, and the haptoglobin is undetectable. So we have pretty good evidence here that the patient may have intravascular hemolytic process. Well, we talk with the patient and let's pretend that this is true. And obviously I picked this up from the internet, but it illustrates some important points I want to bring up. So this patient will tell you, yes, intermittently I have had this dark urine in the morning when I wake up, and that it gets better as the day goes by. And it is this observation that actually led to the name paroxysmal nocturnal hemoglobinuria, because one can show that this dark material in the urine is hemoglobin. Well, something seems to have happened at night. That's the nocturnal, and paroxysmal because there can be times where nothing happens. Well, it turns out that this beautiful name is wrong in every possible respect. Because number one, the hemolysis is not paroxysmal. The hemolysis is not nocturnal, it's occurring all the time. And number three, you do not need the dark urine to make the diagnosis. In fact, many patients will not have episodes of dark urine. I have patients who have had undiagnosed PNH who only had dark urine once in 3 or 4 years. So you really do not need it to make the diagnosis. So to understand PNH, we need to understand a little bit about complement, because without a complement, there is no such thing as PNH. So PNH, complement, is a system that is part of the innate immune response. It's an old system in the body, and it can be activated in 3 ways. There's the classical pathway, which is not particularly relevant for what we're talking about today. There's the lectin pathway, also not relevant. But then there's the alternative pathway here on the right. And this is critical for what PNH is all about. And it is critical because the alternate pathway of complement is continuously active at very low levels, as I will show you in the next slide. But what you see here is a cascade of proteins that get activated, and the end result is formation of what you see below, the membrane attack complex. So there is accumulation of proteins on the surface of red cells, and if this is not controlled, the red cells are destroyed because we poke holes in the surface of the red cell and the hemoglobin is released. Now, this system is very powerful and dangerous, so it needs to be controlled. And in evolution, there's been 2 control mechanisms that are quite important. We have CD55 that blocks C3, and we have CD59 that blocks C5. It's important to know that C3 is also on the surface of red cells. And it's the accumulation of C3 on the surface of red cells that creates problems if we do not have CD55 and CD59. All right, so if we look at what is happening in the alternate pathway of complement, continuously, we have a process that generates low levels of C3b. And C3b is being produced by hydrolysis, and it is being amplified by the participation of 2 important components. One of them is factor B, and the other one is factor D. And if this process gets activated, there is a massive amplification that occurs, and we get C3b activation on the surface of red cells. So it's important to remember this aspect for the disease. The other important thing to know is that proteins on the surface of red cells, in fact, on all cells, can be linked with a tether. It looks like an anchor. And this anchor is actually quite complicated, and it's built in a number of steps. And you can see here the anchor. This is the plasma membrane of the cell. This is the anchor, and this is the protein. And two important proteins for us, as I already mentioned, are CD55 and CD59 that will protect the cells from complement attack. Well, the cells need to build this complex anchor. And this complex anchor is built in a series of steps. Well, it happens that if we develop a mutation in a gene called PIGA, this mutation occurs in a critical step. And if we cannot build the first part of this anchor, we cannot build the anchor. So if we have a mutation here, we lose either completely expression of this anchor and all the proteins that it tethers to the surface of red cells, or we get reduced levels of those proteins. And that will render the cells at risk of destruction by complement. So PIGA. So this gene is very important. It's located on the X chromosome. Men have only one X chromosome, so mutation in one copy, they're done. The cells will have either low levels or absent PIGA. But in women, this is also potentially a problem because in women, even though they have two X chromosomes, one of them only is active because of lionization. So in either men or women, one mutation in PIGA is enough to cause loss of function of this gene and the consequences of it. And as I mentioned, we have multiple proteins that depend on this GPI anchor that are going to regulate complement that depend on the presence of this gene. So we lose CD55, CD59. And in most patients, a mutation is typically a very small, either base loss or base substitution that results in either a frame shift, which results in no expression, or the reduced expression, which is a partial deficiency of the GPI anchor. So we've talked about complement, we've talked about this mutation in PIGA. Well, that mutation has to occur in a stem cell within the bone marrow. And we know it has to be like that because if you look for the consequences of this lack of mutation, you will find them in all the mature cells in the blood. So it must occur here. Well, that mutation is not enough. Somehow, this mutation in the stem cell must expand so that it becomes the predominant contributor to hematopoiesis. And there are various theories that have been developed about this. One of them is that maybe there's an immune attack against normal stem cells, or that there could be second mutations that will give these cells a fitness advantage, and other possibilities. For our purposes, what we need to understand is that there is expansion of these cells to become the dominant component of hematopoiesis. And this is something that can occur, for example, in patients with aplastic anemia, less likely in MDS. And some of you may have seen this type of Venn diagram where PNH is kind of overlaps with aplastic anemia and MDS. Now, when the PNH clone is huge, we call that classic hemolytic PNH. And what we see there are the consequences of hemolysis, which I will talk about. But oftentimes, patients with aplastic anemia and MDS will have small PNH clones. And usually in those circumstances, the PNH itself is a minor component and generally does not need to be treated. But it will predict for a good response to immunologic therapy. So as I mentioned, in PNH, we have hemolysis, destruction of red cells because of this mutation in the PIGA in stem cells. We have the clonal expansion. But the consequence of hemolysis depends on these three features that I have highlighted at the bottom. Number one, we have lost these breaks on the complement cascade. Number two, we have continuous low-grade activation of the complement cascade. And number three is that red cells do not have a nucleus. Nucleated cells have a way of controlling complement activation independent of CD55 and CD59. Red cells do not have that, so they are really vulnerable for complement-mediated attack and destruction. So pictorially, this is what is happening. A normal cell has both CD55 and CD59. We get C3 on the surface of the red cell. Well, that's controlled by CD55. And we do not allow the membrane attack complex to form because of CD59. Well, if we have the red cells with the PNH phenotype, we miss these two proteins. C3 is activated on the surface of the red cell. It results in the formation of the membrane attack complex. We create holes in the surface of the red cell is destroyed. Now, if we use something like eculizumab, which I will talk about in a little bit, it blocks the formation of the MAC. But we can still get accumulation of C3 on the surface of the red cells, and that will mark them for destruction in the reticuloendothelial system, a phenomenon known as extravascular hemolysis, about which I will also talk a bit later. So as I said from the very beginning, in PNH, hemolysis is occurring all the time. But there are some conditions that will increase the rate of hemolysis or the risk of hemolysis, which I will address later. These are called complement amplifying conditions. In the patient with untreated PNH, most, if not all, hemolysis is intravascular. And the reason for that is that the efficiency of intravascular hemolysis is such that the cells do not live long enough to accumulate C3 and lead to their destruction in the liver and spleen. Some, maybe many patients who are on C5 inhibitor therapy can have extravascular hemolysis, and I will explain that a bit later. But what are the consequences of intravascular hemolysis? So we release free hemoglobin into the bloodstream, and that depletes nitric oxide. And nitric oxide is a very important regulator of smooth muscle spasm. So if the nitric oxide is gone, the patient has abdominal pain, esophageal spasm, erectile dysfunction, etc. Nitric oxide is also important for endothelial function. And the endothelium is the lining of blood vessels, which is critical to prevent clot formation. And therefore, nitric oxide depletion and intravascular hemolysis was the patient at risk of thrombosis. And nitric oxide depletion also results in pulmonary hypertension as one of the consequences. And patients with untreated PNH are at risk of kidney damage as well for a number of reasons. Nitric oxide depletion, ischemia of the kidney medulla, the toxic effect of hemoglobin on the renal tubules, etc. So one of the most feared complications of PNH is thrombosis. And before the advent of effective complement inhibitor therapy, up to 60% of patients with PNH will have a blood clot. And in fact, thrombosis was the most common cause of death for patients with PNH in the past. And here I'm showing the complex interactions that exist between the complement cascade and the coagulation cascade. And in particular, how C5 activation can lead to the activation of thrombin. And thrombin, of course, is a very important component of the coagulation cascade leading to thrombosis. But thrombosis is a multifaceted component of this disease. As I mentioned, the endothelial dysfunction, activation of the coagulation system, but also the platelets have the same phenotype as PNH red blood cells. They lack GPI-anchored proteins, and therefore platelets can be activated. So the untreated patient with PNH has a high risk of thrombosis that may be at typical or common sites such as DVT or pulmonary embolism, but also at unusual sites, including splanchnic vessel, hepatic veins, and cerebral sinuses. When we see somebody with PNH, and I'll talk in a minute about the diagnosis, we can classify the disease into three types. We have classic hemolytic PNH, where the features are mainly those of hemolysis, and usually you need a clone size of more than 20% for the patient to have really meaningful hemolysis that will require therapy. PNH with marrow failure syndrome, and usually these will be patients who have either aplastic anemia or MDS, and generally these clones are small. An important observation about the presence of these small PNH clones in marrow failure syndromes. Generally, the presence of a clone would suggest that the marrow failure syndrome is acquired rather than a hereditary marrow failure syndrome. And then we have subclinical PNH, which will typically, these again are very small clones, and sometimes you wonder why testing was done in some of those patients. I mean, clone like 1% or so. So when should we suspect PNH? Well, the patient who has a hemolytic anemia, so they'll have anemia, high retic count, Coombs is negative, and we have evidence of intravascular hemolysis, typically with elevated LDH, low haptoglobin, and urine hemosiderin. If the patient has suspected PNH, we need to make sure that the patient does not have a blood clot. I always check a D-dimer in these patients, and I worry quite a bit if their D-dimer is elevated, because that suggests that the patient is at substantial risk of thrombosis. Any patient with a marrow failure syndrome should have testing for PNH done at least once. And we also should think of PNH in unusual situations, a patient with unexplained muscle spasms, renal insufficiency, abdominal pain that is unexplained, unexplained pulmonary hypertension, or unexplained iron deficiency. In fact, one of my patients with PNH was remarkably referred to me from a neurologist because of muscle spasms that they could not explain. And the patient was a bit anemic, and the referral was anemia and muscle spasms. So that was actually a very nice way to come up with a diagnosis and provide a therapy for the patient. So the gold standard test for diagnosis is flow cytometry, as I will show you. So when we do flow cytometry, we want to determine whether there are cells with the PNH phenotype, and we want to look at monocytes, neutrophils, and red cells. And we need to look at these three populations because we want to prove that the problem is occurring at the level of the stem cell, as I mentioned earlier on. And it's also important to look at the numbers, and the clone size, which is measured by looking at monocytes and neutrophils, they look similar to each other. When it comes to red cells, rather than looking at CD55 and CD59, we like to use the FLAIR reagent, which directly measures GPI. So here is a normal person, and we can see this is the red cell population. We have a uniform population, and here all the cells are FLAIR positive, so they express the GPI anchor. Here we're looking at neutrophils with CD24, and again we see that the cells express the GPI anchor, and the same with the monocytes. So if the patient has PNH, then what we expect is that we're going to see a population that is FLAIR negative, which should be here and here for the neutrophils, and we should see a population in this quadrant here because they will be red cells that lack the GPI anchor. Well, here is an example of such a patient. We see many red cells that lack the GPI anchor, and the same with monocytes as well. Sorry, monocytes here and neutrophils here. So clearly this patient has a PNH, and this is a substantial clone. Notice that we have nice separation here between the normal and the cells with complete loss of the GPI anchor. Now I'm going to show you another patient who has a different flow cytometry pattern, where we can see that, yes, there are cells that lack completely the GPI anchor. These are the so-called type 3 cells. But then there's a second population here of partial GPI anchor deficiency. And you can see it in this population here in yellow. So this patient has both type 2 partial deficiency as well as type 3 complete deficiency of GPI anchor in red cells. So you notice here that the clone size is more or less the same based on granulocytes and monocytes, about 73%, a rather large clone. And the size of the clone by red cells is very low. That's because the red cells are being destroyed. And with therapy, we expect that the red cell clone size should increase as the cells are surviving. So how do we treat the patient? So as I mentioned already several times, the problem is that the complement cascade is active. And currently we have 3 drugs that are able to regulate complement activation. The first product was eculizumab, which blocks C5. Then we had ravulizumab, which also blocks C5. The difference between eculizumab and ravulizumab is that ravulizumab has longer pharmacokinetics, so it can be given less frequently. Eculizumab every 2 weeks, whereas ravulizumab is given every 8 weeks. And then since 2021, pegcetacoplan was approved, which inhibits C3. But other drugs are being developed, and we have now quite a bit of interest in so-called proximal complement inhibitors. One of them is iptacopan, that inhibits factor B, danicopan, which inhibits factor D, and there is another product, which I'll talk about it close to the end of my talk, which is vermicopan, which is similar to danicopan and also blocks factor D. How do we treat patients, and when should we treat patients with PNH? So there are many considerations that come into play. One of them is the clone size. Generally, larger clone sizes need therapy. What is the hemoglobin? Does the patient need transfusions? What are the PNH type cells? Are they type 2 versus type 3? In general, type 3 with big clones need therapy. Type 2 with small clones, maybe those patients can be observed. Any patient with a history of thrombosis and the PNH clone should be treated with complement-directed therapy. And of course, also what sort of comorbidities the patient has. If the patient has problems with kidney disease, pulmonary hypertension, etc., or the patient cannot tolerate anemia very well, those patients need to be treated. Currently, we can use eculizumab or ravulizumab or pegcetacoplan for treatments. The role of anticoagulation is interesting. In the past, patients with a clone size more than 50% would be prophylactically given anticoagulation. Nowadays, if the patient has no history of a blood clot and is started on effective complement-directed therapy, those patients do not need anticoagulation. And the group in Leeds, who have considerable experience with this disease, have shown that the risk of thrombosis actually goes down dramatically with effective anti-complement therapy. These patients need supportive care with immunizations. The patient is going to receive eculizumab or ravulizumab. They need the meningococcal vaccine. If they're going with pegcetacoplan, they need both the meningococcal vaccine as well as vaccination against Haemophilus and pneumococcus. And these patients need iron and vitamin supplementation. We can control complement as much as we like. If the patient is iron deficient, the hemoglobin is not going to get better. And it is perfectly safe to give iron replacement therapy once the complement cascade is controlled. I've done it, and there is no flare of hemolysis whatsoever. Patient education is critical, and I think the person with this disease really needs to understand the biology of the disease, the rationale behind therapy, and the various ways of treating this disease. Because it's, of course, a lifelong disease, and the consequences of not being on therapy are significant. So, there have been 5 or 6 studies that led to the approval of the currently available 3 drugs. Eculizumab, based on the TRIUMPH and SHEPHERD trial studies, ravulizumab, which was based on the 301 and 302 study, and then Pegasus, which led to the approval of pegcetacoplan. What happens if we treat with a C5 inhibitor? And this is a summary of data from the group in Leeds quite a few years ago. There's clearly an improvement in intravascular hemolysis. The LDH often goes down dramatically, if not to normal, close to normal. There's an improvement in hemoglobin, and as I already mentioned, the incidence of thrombosis goes down dramatically once C5 inhibitor therapy is initiated. Level of fatigue goes down, and fatigue is a very important symptom of patients with this disease. Symptoms of smooth muscle spasm go away because when we block intravascular hemolysis, we're no longer depleting nitric oxide, and the transfusion requirements also go down dramatically by around 75%. This is data from Dr. Brodsky's study going back to 2008, and you see what happens when we start therapy with eculizumab, or in fact any other complement inhibitor that is available. Clone size based on red cells is low, But when we block complement, the red cells are surviving longer, and therefore the clone size increases, and the therapy does not lose its effect. I mean, the red cells remain at a higher level continuously. And with the improvement in hemoglobin, we also expect an improvement in the facet fatigue score, which has been a very important tool in the monitoring of patients with this. As I mentioned here, the need for transfusions goes down quite dramatically once the patient has been on eculizumab, and the therapeutic effect is maintained long term. Well, subsequently, ravulizumab became available, and the advantage of ravulizumab is that it is recycled in the endosome, and therefore it has a much longer half-life, and it has better pharmacokinetics. And as a result, the drug only needs to be given every 8 weeks, and this is data from the 301 study. And this was a well-balanced study between eculizumab and ravulizumab with respect to any parameter that you care to look at. Now, this study was not powered to be a superiority study. It was designed to be a non-inferiority study compared to eculizumab. And in that study, ravulizumab met all the outcomes of non-inferiority. In fact, many of us who treat patients with this disease will think that ravulizumab is actually a superior product. In particular, the risk of breakthrough hemolysis is lower with ravulizumab compared to eculizumab, and I will talk about this a little bit later. Look at various metrics. They prove the non-inferiority of ravulizumab. But as you can see, yeah, the confidence intervals are kind of wide, but everything more or less is in favor of ravulizumab. As a result of this study and its approval, ravulizumab became the preferred product because of the less frequent dosing. And as you can see, ravulizumab is quite good at controlling intravascular hemolysis in the vast majority of patients. And again, the therapeutic benefit is sustained, unlike cancer, where patients kind of relapse and the therapy fails. With these products, the therapeutic benefit persists. We look at the additional outcomes on these patients. Fatigue goes down significantly. The risk of abdominal pain goes down. Dyspnea, dysphagia. So everything is better on C5 inhibitor therapy, and ravulizumab in general is the preferred product. This is data from the group in Leeds, and I think this data is quite important because there are very few occasions, in my view, in medicine where we give a therapy that alters the natural history of the disease and gives a person a normal life expectancy. So before complement therapy became available, the median life expectancy of a patient with PNH was about 12 to 14 years. And we have to remember that many patients with PNH are actually quite young, in their 30s and their 40s. And here we can see that before the era of eculizumab, this was the average survival of patients with PNH. This is how it improved with eculizumab. And if you look at patients with PNH and compare them to age and sex mesh controls, the numbers are indistinguishable. So truly a remarkable observation, and I think a big triumph in medicine. Well, that's all well and good, but in 2010, with the introduction of C5, a new phenomenon emerged. And I want to spend a minute talking about this because I think it's quite important. So this is a patient with PNH. On the left here, before treatment. So we have a very, very high clone size. We have low hemoglobin, reticulocyte count is very high. We start therapy, hemoglobin improves. Size of the clone increases as expected. The red cells are surviving. But we also see that many of the red cells now have C3 on their cell surface. And we can see it here, that 76% of the cells have C3d on their surface. Now, why is that happening? That is happening because, remember, I talked about two complement regulating proteins, CD55 and CD59. Well, C5 inhibition replaces the effect of CD59, but it does not replace the effect of CD55. So, because the complement cascade is continuously active, we still accumulate C3 on the surface of red cells. And that is what we're seeing here. And that results in this phenomenon of extravascular hemolysis about which we'll talk. Well, there's been a lot of discussion lately about response criteria in PNH. And I bring this up because it's becoming more important in Europe. I don't think it has really taken off completely, but this classification suggests various levels of response based on hemoglobin and transfusion requirements, and probably will be used in the future, especially in clinical trials. So many patients with PNH will continue to have some anemia, even though they're on C5 therapy, and while they're receiving adequate C5 inhibitor therapy. So if that is the case, we need to look at other things. As I mentioned, iron or other nutritional deficiency. Could the patient have an associated marrow failure syndrome? Because if the patient has an associated aplastic anemia, we cannot really expect the hemoglobin to return to normal. And in that situation, the reticulocyte count, white count, and platelets are very important. If the retic count is low and the white cell count is low, well, maybe we're hitting now the marrow failure component of the disease, and that's why the hemoglobin is better. There could be inflammation, and we know that especially in untreated PNH, cytokines are quite active because of the complement cascade and that can result in a component of anemia, chronic kidney disease, or there could be persistent intravascular hemolysis, which is kind of unusual if you treat with C5 inhibitor adequately. Two important things that could result in persistent anemia. One of them is breakthrough hemolysis. Usually this will be an intermittent phenomenon, and typically this occurs before the next dose of the complement inhibitor is given. It was more common with eculizumab than it is with ravulizumab, but one way to figure this out is to check the trough CH50 levels. So if you're worried that the patient is having persistent intravascular hemolysis, you check a trough level. If complement is blocked, that is not the reason. And typically, if there is intravascular hemolysis, one would expect the LDH to be elevated and the bilirubin to be elevated. But if the patient is anemic, the CH50 is low, so complement is blocked, the Coombs test may be positive, although you do not need it, and the retic count is high, then one needs to think about extravascular hemolysis, which occurs in maybe 10 up to 25% of patients, perhaps more. And this is what actually in part led to the studies of pegcetacoplan. Now, pegcetacoplan is a cyclic peptide that blocks C3. And the idea behind it is that if we block accumulation of C3 on the surface of red cells, we can prevent this phenomenon of extravascular hemolysis, but we can also block intravascular hemolysis. And the Pegasus trial looked at patients who were already on eculizumab with a suboptimal response to that agent and randomized them to continue with either eculizumab or pegcetacoplan. But before they were randomized, all patients received therapy with both drugs. And as you can see, when both drugs are given, the hemoglobin improves, and then the randomization occurred. So half of the patients went back on eculizumab, which is standard of care at that time, or the other patients continued on pegcetacoplan alone. And pegcetacoplan led to a higher hemoglobin for the duration of the study. In fact, the hemoglobin got better by about 3 grams. The need for transfusions went down quite significantly. And as a result, if you look at these curves, pegcetacoplan appeared to be somewhat better than eculizumab with respect to freedom from transfusions, improvement in hemoglobin, etc. And this led to the approval of pegcetacoplan in 2021. So After talking about C5 and C3 inhibition, we need to talk a little bit about an important phenomenon, which is known as breakthrough hemolysis in PNH. And breakthrough hemolysis is the intravascular hemolysis. So it will be associated with a drop in hemoglobin, rise in LDH. The patient may have symptoms of intravascular hemolysis again, things like abdominal pain, esophageal spasm. And it may or may not be associated with hemoglobinuria. As I mentioned, hemoglobinuria is not required to make the diagnosis of this disease. There are two types of breakthrough hemolysis. One of them is pharmacokinetic, and this relates to the fact that the drug concentration reaches a level which is not enough to block complement. This is less common with ravulizumab than it was with eculizumab. In fact, in the 302 study, no patients had breakthrough hemolysis on ravulizumab. But there's a second, perhaps more important type of breakthrough hemolysis, which is known as pharmacodynamic breakthrough. And this results because of complement activating conditions. So complement components are acute phase reactants. So if there is an infection, inflammation, pregnancy, surgery, or vaccines, complement components can increase in concentration, and the drug may not have a concentration that is enough to block it. And as a result, there is reactivation of intravascular hemolysis. How do we manage breakthrough hemolysis? First of all, we try to avoid it as much as possible by making sure the patient is compliant with therapy. If the patient is going to have any elective surgery or vaccines, these should be done or vaccines given as soon as possible after a dose of the antibody, so that they have maximum concentrations of the antibody, and therefore there is room for any acute phase response to be accommodated. We treat the underlying cause. So if there's an infection, we take care of that. The patient must inform the team immediately if they have a complement amplifying condition. We monitor for hemolysis and we transfuse as needed. And depending on the timing of when this breakthrough hemolytic event occurs, the patient may need dosing with a complement inhibitor. And guidelines are being developed in this regard. Last year, my friend, Professor Luzzato, actually published a very interesting editorial in the New England Journal of Medicine looking at the risk of breakthrough hemolysis in PNH. And I think these pictures are actually quite interesting. So if we have a patient with untreated PNH, we see that hemolysis is intravascular because we have no protection, both against the membrane attack complex as well as C3. Now, if we have, if the patient is on a terminal complement inhibitor, and then we get a complement amplifying condition. If we have incomplete block of C5, we have very little escape and MAC formation, and therefore breakthrough hemolysis will be kind of mild. But if we have a C3 inhibitor that is being blocked, but we get amplification of C3 production because of an acute phase response, and if the drug is not present in enough concentration to control the C3, we could be at some risk of significant hemolysis because of the amplifying nature of the cascade. So they're proposing that perhaps some patients could be treated with both a C5 inhibitor and a C3 inhibitor, because then there is much more latitude for this acute phase response, and we can have protection from breakthrough hemolysis. Well, the field is developing very rapidly, and now we have more proximal inhibitors that are being studied and probably soon approved. And I mentioned earlier on the alternate pathway. We have factor B and factor D. And factor B and factor D are critical for this takeover mechanism that keeps C3 being activated. And they're also quite important for the amplification step that occurs when there is a need for complement activation. And we have several drugs now that are targeting factor B and factor D. So I mentioned already danicopan and vimurcopan, both produced by Alexion that target factor D. We have factor B that is being studied in the form of iptacopan that that is produced by Novartis. And there are other C5 inhibitors that are being studied, including monoclonal antibodies as well as siRNAs at various stages of development. I want to spend a couple of minutes talking about two oral agents that are likely going to be approved for the treatment of PNH. And the first was the APPLY study that was presented at ASH last year. So this was a study of patients with PNH who had a clone size of more than 10% with evidence of extravascular hemolysis, and they were randomized to iptacopan versus standard of care C5 inhibitor therapy. And patients were initially given therapy for 168 days, and then the patients could be switched to the oral agent instead of the C5 inhibitor. And the data that was presented reflected the first 168 days of observation. We can see here the patients on iptacopan had a very good response to therapy. Most patients did not need any transfusions. About 68% of patients got a hemoglobin that was at least 12 or higher. And transfusion avoidance was reported by 96% of patients on the iptacopan group versus the patients on eculizumab. As you can see from this figure here, the response to iptacopan was actually very fast, kind of peaking already within about 4 weeks of initiation of the agent, and the hemoglobin was maintained at around 12 grams or higher for the duration of the observation. Similarly, the LDH was controlled, so we have good evidence that intravascular hemolysis is also well controlled. In fact, the LDH was pretty much the same for both the C5 inhibitor and iptacopan. I mentioned already this breakthrough hemolysis phenomenon, and the rate of breakthrough hemolysis was actually numerically lower for iptacopan compared to standard of care C5 inhibitor, and the risk of thromboembolic events was pretty much the same. In fact, the only transient ischemic attack that was reported in the iptacopan arm was thought by the investigators to be unrelated to the use of this agent. So no increased risk of thrombosis, really very little risk of breakthrough hemolysis. Drug was very well tolerated. Some patients developed headaches and some diarrhea, but otherwise very little risk of significant toxicity. Another agent that is being studied is vemircopan, which is a factor D inhibitor. So factor D is a cofactor for factor B. And factor D is not an infused phase reactant. So this is a small study that was also reported at ASH last year, where patients with treatment-naive PNH were treated. The numbers are small, as you see, about 11 patients. And first 12 weeks of observation were reported. Again, we see a rapid improvement in hemoglobin to values that look more or less normal. And again, the hemoglobin levels tend to be sustained. And concomitant with improvement in hemoglobin, the LDH goes down into the normal range. So it appears to be another very powerful agent that blocks hemolysis. A couple of comments about these complement amplifying conditions. An important one is pregnancy. Remember, quite a few of these patients are young, and a young lady with PNH requires quite a bit of education on how to go about pregnancy with this disease. Now, in the past, pregnancy was almost an absolute contraindication for a person who had PNH, but that's no longer the case. Because again, there have been quite a number of studies, mainly from the group in Leeds, which shows that if the patient is treated properly with eculizumab, which is the only approved complement inhibitor for pregnant women, pregnancy can be managed safely. These patients were requiring changes in the dose of eculizumab as pregnancy moves along, not only because of changing the weight of the mother, but also because of the possibility of complement activation. These patients should be anticoagulated with low molecular weight heparin, and such patients should be co-managed with a high-risk obstetric specialist because there are risks both to the mother and to the baby. The levels of eculizumab in the cord blood is actually very, very low, if at all. And it can be also present in small amounts in breast milk, but those are not reasons not to breast milk at the baby. As I mentioned, an elective surgery should be performed soon after the complement inhibitor has been given, so that we have maximum levels. And if there is emergency surgery, then one needs to talk with a PNH specialist about what will be the optimal plan at that time with respect to maintaining complement under control. Infections should be aggressively treated, and again, vaccines should be given as soon as possible after C5 or complement inhibitors to minimize the risk of breakthrough hemolysis. One final slide about allogeneic transplant in PNH. It used to be said that allogeneic transplant is a cure for this disease, and perhaps that is true, but studies have shown that a patient who is properly managed with complement inhibitor therapy has a normal life expectancy. One cannot say the same for a patient who goes to an allogeneic transplant, so it is no longer the standard of care. The only times where a transplant should be considered would be the patient who has ongoing hemolysis despite optimal therapy, and there the risk from the transplant is quite substantial. And such a patient should continue on a C5 inhibitor until at least full donor chimerism. And such a step needs to be taken after a lot of consideration because of the risk of thrombosis, morbidity, and mortality. I will stop there, and I hope we have some time to answer questions. Thank you for your time.
We do have several questions online. First is, does general inflammation in the body change how PNH patients respond to complement inhibitors? Is there anything specific that can be done to lower inflammation?
That's an excellent question. So, as I mentioned earlier, the complement cascade is an acute phase system. So, it is in the presence of inflammation, and inflammation can be triggered by many things: infection, surgery, autoimmune conditions. The complement cascade can be activated, and there is a risk at that point in time that the therapy that we're providing may not be enough to block complement activation. So, in these scenarios that I mentioned, so infection, inflammation, planned surgery, pregnancy, vaccines, the person needs to be liaising with their PNH team to make sure that the patient goes through that episode as safely as possible. Now, the underlying cause of this complement amplifying condition should be treated. If it's an infection, the patient needs to have appropriate antibiotic therapy if we think it's a bacterial infection, or if it's a viral infection, we treat it appropriately. Surgery, well, we need to deal with that as best we can. And with vaccines, as I mentioned, it's critical to give the vaccine as soon as possible after the antibodies or any therapy targeting complement is given, so that we minimize the risk of breakthrough hemolysis. Yeah, that's how it is. There will be guidelines coming up.
Thank you. What other issues can arise if both C3 and C5 are not blocked, and can it cause low platelets as well if both are not treated if patient with both EVH and IVH?
So this idea of blocking both C3 and C5 so far is a theoretical concept that I'm not aware that it has ever been done. What I can say is that there is a study, and perhaps there'll be a drug approved soon, where an oral agent, danicopan, which blocks factor D, will be given to patients who are on a C5 inhibitor who have an incomplete response, or they continue to remain anemic and they have extravascular hemolysis. The So the idea is to prevent intravascular and extravascular hemolysis. Now, if I understood the question correctly, are there scenarios where both of these systems can be overwhelmed? I suppose it's possible if there is, say, severe sepsis. But if there is severe sepsis, there are things that can be done to mitigate that. For example, the concern in that scenario would be that the patient would have a catastrophic intravascular hemolytic event. If there's the concern about that, what one can do, one can give an extra dose of the C5 inhibitor. For example, the patient is in the hospital with severe sepsis. The patient can be given a dose of eculizumab in the hospital. So we're providing much better protection against C5 activation, and we're preventing the membrane attack complex from forming, and therefore protecting red cells from being destroyed. The other thing to remember, of course, the person is very ill, let's say, because of surgery, and the patient is being transfused. That patient who's being transfused is called protected because the red cells we're providing are not going to be PNH cells. So those cells are going to be normal cells, right? But if there is a concern, the patient can be treated with an extra dose of a C5 inhibitor, which would be the safest thing to do in such a circumstance.
Thank you. If white blood cells and platelets also bear the PNH clone, why does there seem to be no damage to those lineages like there is to the red blood cells? Do white blood cells and platelets still function normally in these patients?
People were paying attention. Yes. So as I kind of mentioned, PNH is a very peculiar disease, in part because the red cells have no nucleus. So nucleated cells have a mechanism of containing complement activation on their surface and preventing formation of the MAC. Whereas red blood cells are not able to do that. Okay? And now the reasons for that are kind of complex, but you have to believe me. That's how it is. And platelets can be affected by the PNH phenotype. In fact, that's part of the reason why patients with PNH are at increased risk of clotting, because platelet activation is an important component of coagulation. In fact, a lot of coagulation occurs on the surface of platelets.
Thank you. We'll do another online question, and then we have a question from Jacksonville. As a PNH patient, I would like to understand how could we control if the anticoagulation is working. I really get this. I really get this point. Thank you. They may have meant I really don't get this point, but shall I repeat that?
Yeah, you can, please.
As a PNH patient, I would like to understand how could we control if the anticoagulation is working?
All right, so I'll try to answer that in two ways, okay? So one way, if a person is on anticoagulation, then there are laboratory tests that can be done to look at that. So for example, if the patient is on warfarin, there is the INR that can be tested, and there are targets for that. Or if the patient is on one of the more modern direct acting anticoagulants, then there are blood tests that can be done to make sure that the person is achieving. Of course, on a practical level, the absence of blood clots will be also supportive of that. Now, if the patient is not on a blood thinner and they're on a complement inhibitor, okay, the way we understand how coagulation occurs and the interplay between the coagulation system and PNH, the observations would suggest that the patient whose PNH is controlled with anti-complement therapy, the risk of thrombosis appears to be very low.
We have a question from Jacksonville.
Will we speak?
No, just speak up, don't hear you.
Yeah, you had a good presentation. I like the information you gave us. The question I had here, can you hear me?
A little bit louder, please.
Oh, okay. The question I had, you had a lot of graphs for C3 blockade and C5 blockade. And I think their chemical name is Sumab or something like that. technical name, trade name is probably Solarisis or something like that. The question I had, the graphs you showed, by taking those blockade before and after, the after it goes all the way to 12 hemoglobin level. Now that information, you got it from your experience or you use the company supplied information?
I'm afraid I did not understand all the question.
Yeah,
No, the graphs you had for some of these treatments, is that based on your experience with the patients or is the company supplied information?
he's asking what the data you showed. Is it something from your experience or from drug companies?
Yes.
So the data is all from published literature. But my experience with these products is tallies with this. And of course, some of the products we do not have experience because they're not approved. For example, I have no experience with vermicopan, but the data is out there. There's no the data that I reported here today is all from peer-reviewed publications, and there's no reason to think that it is not.
Well, so you use these company supply information, and yet there's no reason to believe they are not correct. The question I have, PNH is a rare disease. The drugs that are developed for rare disease are called orphan drugs. Orphan drugs do not have the same standard for approval process by FDA compared to the regular drugs. So these companies, they come up with these all fancy names for the drugs, charge overpriced for these things here, barely they're effective. I used last year Solarisis. I paid $1 million for a year treatment and nothing happened. That was my question. And the company supplies beautiful graphs before and after.
I get your question. So I can tell you this, okay? I've treated quite a few patients with this disease. And the patients who are properly treated, we achieve these responses that have been reported in the literature. I mean, for example, if I'm allowed, let me go back a few slides, okay? So this slide, this is a composite slide that I took from a report that came from a group in Leeds. The group in Leeds treats approximately 700 patients with this disease, okay? I know these people personally. That's why I'm citing their work. And they're respected worldwide for their experience with this disease. This is real-world experience outside of clinical trials. Okay? And I can tell you, we've treated, my colleagues and myself have treated patients with ravulizumab, we see the same type of responses. We've treated patients with pegcetacoplan, we see the same type of responses. I have actually treated one patient on an expanded access program with an oral agent. And my experience with the product is essentially the same as I showed you here. I could plot the hemoglobin of my patient after starting therapy and it will be indistinguishable from this curve.
I felt like you also I think he also was talking about orphan drug designation and maybe not getting as much data or length of time. I'm not sure. I kind of feel like I heard a little bit of that. Yeah.
So these are, you're right, these are rare diseases. But I mean, we have been treating these patients now for a number of years, and there are international registries that incorporate patients from all over the world. In fact, I've been fortunate to publish research based on this type of accumulated wisdom about treatment of this disease. So these observations and post-approval follow-up has been ongoing for a number of years. and the results actually are consistent and long-lasting. So I personally, I do not have any concerns that because the number of patients treated is small, that the results are not reliable. These are studies that are before they actually are run, they are approved by the FDA and by experts in the field.
Thank you. And I would direct the patient to, we have more information on the AMDSIF website and a patient summary of recent research reported at ASH, the American Society of Hematology. So that might be helpful to find some more detailed information. And I believe we have a question from Phoenix.
No questions from Phoenix.
Oh, okay, thank you. We have, go ahead. We have one here in Rochester.
Thank you, David, for this question. We were talking a little bit about it and reviewed some of those trials. And the indication for starting therapy, I think you put it nicely there, is a bit tricky. Even some of the trials even were switch over after a month or two. So they even didn't question why was the patient started. So going back, like in MDS, not every patient needs to be treated. In PNH, not every PNH patient needs to be treated. So the fact of finding hemolysis and a big clone, but not with significant anemia. I know that commonly, if it's a big clone, there is significant anemia, but I have a couple actually. There's the clone is 60, 70%. They're probably type 2, but their hemoglobin is 11, 12, and the LDH is 3 times higher than normal.
Yeah, so that's a very, that requires some thought. In general, the idea has been that if the LDH is more than 2 times the upper limit of normal, one thinks about therapy. Not because of the anemia. I think we should not just say we treat because the patient is anemic. I fear more the thrombotic risk that these patients have. And some of these patients may have a thrombosis, and that's the end, right? I mean, if they have a catastrophic vascular event, it would be a serious problem. So if the patient has an elevated LDH more than 2 times the upper limit of normal, I will check a D-dimer. If the D-dimer is elevated, I would probably be inclined to treat that patient. Now, if the clone is small, then the answer is easy, right? I mean, 1% clone, even if you treat it, the hemoglobin is going to go up by 1%, even if you fix it, right? 1% clone, 1% improvement in hemoglobin. So if the hemoglobin is 10, it becomes 10.1 or 10.01. So we're not going to see a benefit there. But if the clone is above 20%, the LDH is above twice the upper limit of normal, I think most people in the field will think about treating the patient.
I have another online question. Is there a benefit to be on both Empaveli and Ultomiris? And for what reasons? There are a few patients I know who are on both.
So personally, I've never done that. The only reason to do something like that would be to avoid this problem that I kind of hinted at. So if the patient is on adequate C5 inhibitor therapy, we should not get intravascular hemolysis. Maybe the hemoglobin will improve, maybe it's not normal, but the hemoglobin will get better. If we do not give C5 inhibitor therapy and we give a C3 inhibitor, then we can inhibit both intravascular and extravascular hemolysis. The hemoglobin may be very good. And the patient could do fine. In fact, we have patients who are on hexatracoplan alone. The only reason to do both, if you're really afraid that this phenomenon that I have in this figure on the right occurs, that the patient is at risk of a massive intravascular hemolytic event. Now, these are very rare occurrences, okay? And then unless the patient is going for big surgery or has emergency surgery, personally, I don't see any reason why the patient should be on the 2 drugs. There's no clinical trial that has shown that patients need to be on long-term with both drugs. And that's important. Perhaps somebody is treating patients, as in the 4 first 4 weeks of the Pegasus trial. That's the only time that I know that it has been done, where the patient is receiving both Ultomiris or Soliris, more or less the same thing, and pegcetacoplan at the same time. That was the first 4 weeks of the study. But I'm not aware of any patient that is on both products at the same time.
I have a question.
Yes.
When you have a patient on either a C3 or a C5 who continues to have problems with either low hemoglobin or chronically low platelets, do you think that there's still something else going on in the marrow that you don't know, that maybe they're not aware of?
Yes, in fact, I have a slide for you. So yeah, persistent anemia and PNH is common. Okay. And one is to understand it in a rational fashion, because there could be different reasons, different people. And the only way to understand it is to go systematically what the possibilities are. So is there evidence of hemolysis ongoing? Is it intravascular or extravascular? If the LDH is more or less normal, less than 1.5 the upper limit of normal, people would say intravascular hemolysis is not occurring. If CH50 is low, we have good pharmacologic blockade of C5 territory. But if the retic count is low, then I think, is there a deficiency of iron or some other mineral, or is there an element of marrow failure? That's when I look at what the white count and platelet count. If both the white count and platelet count are also low, well, no complement therapy is going to improve. So that suggests that the patient has a marrow failure syndrome, and I will focus on that.
Maybe like an aplastic anemia.
Yes. There is an overlap between these conditions, and in fact, I also had a Venn diagram about that. And there's a reason for putting that. I mean, I can talk forever about this, but
Right.
this Venn diagram is actually very nice because it illustrates that the disease is not static. Neither PNH nor aplastic anemia are static diseases. And this is well known. Patients have PNH with evolved to aplastic anemia, and there have been patients with aplastic anemia, small PNH clone. The aplastic anemia is treated with immunosuppression, the clone gets bigger. And all of a sudden, the patient develops hemoglobinuria. I've actually had a couple of those patients myself. And then, in time, the patient becomes aplastic again. So these things happen. These are being very well described. And it also, thank you for reminding me, I should also mention that the clone size should be monitored at least once a year, sometimes twice a year, because the clone size can change with time.
Yeah. And then my other question with regards to iptacopan, did any of your slides show half-life? I just think about 3 times a day. If a patient misses a dose, how big of a deal is that in terms of risking hemolysis?
Yes. So iptacopan is twice a day.
Twice a day?
Twice a day. Danicopan is 3 times a day, and vermicopan is twice a day.
Okay.
Yeah, so these drugs need to be given, and compliance must be quite good.
Yeah.
I have a patient already on it, doing very well.
Yeah.
Is there a risk that if the patient misses doses that there could be hemoglobinuria? Possibly, but it's also true that the drugs work very rapidly. So if a patient misses a tablet and they take it a few hours later, probably
Right.
no big deal. I mean, that's the only way the short half-life explains this, right?
Yeah.
Why the patient responds very quickly.
Right.
Yes, sir.
Maybe 2 questions, Dr. Dingli, and a really great talk. Thank you for presenting. The first, and maybe this is more from patient perspective, this therapy does not change the behavior of the disease, meaning the potential clonal evolution of developing MDS or aplastic anemia. Is that right?
That is correct. The therapy, all therapies that we have are directed at complement regulation. where the current therapies do not deal with the fact that we have a deficiency of these complement regulatory proteins, and it does not deal with the underlying dynamics that is occurring in the bone marrow, which is this clonal expansion.
The second question, and that is maybe something I haven't experienced before, but in your experience, these classic PNH patients, when they evolve into MDS, do they continue to have the PNH features?
So the clone can persist, but in time, the clone can get smaller because the neoplastic component becomes more important. Now, if you have a patient who has a clone that is almost 100%, okay, in those clones, in those patients, I always check for BCR-ABL and I check for JAK2, okay? Because these have been reported. And there have been at least one example where the patient had a clone of 100%. And at the same time, the patient had BCR-ABL at very high titers. So clearly there was only one clone. The clone had the PNH phenotype, the gay mutation, and they had BCR-ABL. So CML with PNH. Okay? That patient was treated with a TKI. And guess what happened? The clone went away. So this has been reported. So I look for this type of things in this patient. And we had a patient here recently with Dr. Gangat, and she talked to me about this patient. Again, a patient with myelofibrosis, transfusion dependent. And the PNH clone that was massive, reticulin that was 100%. So this was the same thing. The patient has a myelofibrotic clone with reticulin that also acquires the PNH phenotype, double hit. So the patient has the downside of a myelofibrotic process, and at the same time, a PNH phenotype leading to even more anemia than one would expect with myelofibrosis. It's unfortunate we don't have a target for reticulin.
Maybe last question, at least from the medical standpoint. Do you foresee that in the maybe 10 years, 15 years, any role for CRISPR gene editing therapy in this situation?
Yes, there will be, and those things are being studied already in this disease. The other thing that is being studied is siRNAs, therapies that will silence C5, for example. In fact, I have this on a slide too. If we look here, this box, there is pozelimab and camdisiran. Camdisiran is an siRNA that actually targets C5 in the liver. So there are many interesting ideas going around on how to treat it.
Thank you, Dr. Dingli, for sharing your time and expertise with us today.
Thank you.
If you would like to watch this session again at a later time, it will be available on the conference platform in the next hour by accessing the session and clicking on replay, or by navigating the on-demand tab in the platform hub. If we were not able to answer your question today, you can send it to us at any time in 3 ways. Send an email to help@aamds.org, call the AAMDSIF helpline at 800-747-2820, or submit a question on our Facebook page. If you are watching online, please take a few minutes to complete the session survey. Your input is important to us and helps us plan future educational programming. Also, be sure to visit the exhibit hall and chat with the conference sponsors. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and for making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to help you and your family as we have for the past 40 years. This concludes the session.